Welcome to Roadmap to Residency Evidence-Based Applications. So in this video, we will be going through a quick recap of immune response to diseases. I have covered this section in detail in the immunology module. So this will be just a brief revision for you guys for some topics. So here we have which of the following is the most likely underlying diagnosis. A 13-month-old boy is brought to the emergency department due to cough and increased work of breathing. The patient's presence. Parents immigrated to the United States when he was 6 months old. He has a history of recurrent otitis media, pneumonia, and thrush, as well as chronic diarrhea and failure to thrive. On physical examination, he is tachypneic and has perioral cyanosis. A chest radiograph shows bilateral interstitial opacities. The patient is admitted to the hospital and undergoes bronchoscopy. Analysis of the bronchoalveolar lavage fluid reveals pneumocystis jirovecii. Which of the following is the most likely underlying diagnosis? A gamma globulinemia, chronic granulomatous disease, cystic fibrosis, primary ciliary dyskinesia, severe combined immunodeficiency, terminal complement deficiency. So this is a case of severe combined immunodeficiency, which is a gene defect leading to failure of T cell development. So there is B cell dysfunction due to absent T cells. The inheritance is X-linked recessive and autosomal recessive. The clinical features are recurrent severe viral, fungal, or opportunistic infections, failure to thrive, chronic diarrhea, and the treatment is stem cell transplant. Always remember, in children, severe; in adult, chronic immunodeficiency. Okay. Now, which of the following is the most likely mechanism responsible for this patient symptoms? A 56-year-old woman comes to the emergency department with facial swelling and difficulty breathing. She woke up today with a feeling of fullness in her lips, and 2 hours later, her husband said that her lips looked puffy. There is no itching or skin rash. The patient has had no similar symptoms before. She has a history of gastroesophageal reflux disease and takes lansoprazole daily. She has also began taking lisinopril 2 months ago for hypertension, and the patient's blood pressure is 125, 135 upon 75. On examination, there is moderate swelling of her lips and tongue, mild audible stridor, without wheezing is present. Which of the following is the most active mechanism responsible for this patient's symptoms? Now, there in this vignette, the examiner wants you to get confused between either it is a drug-induced reaction or it is just a simple anaphylactic reaction. The options here are bradykinin accumulation, hereditary C1 esterase inhibitor deficiency, IgE-dependent mast cell degranulation, increased renin saturation, or non-immune mediated mast cell degranulation. You can just pause the video and think about it for a second. So causes of angioedema. So there are typically two important causes of angioedema. It can be either due to mast cell activation, which is typically seen in type 1 hypersensitivity reactions, or direct mast cell activation due to opioids. It's generally associated with pruritus and urticaria, and excess bradykinin is due to AC inhibitors and C1 inhibitor deficiency, where there is no pruritus or urticaria. So angioedema is a rare and potentially serious adverse effect of AC inhibitor therapy. Symptoms typically appear within days of initiation, but can also occur after weeks to years of therapy. Now, although angioedema can affect any tissue, which can most commonly involves the tongue, lips, or eyelids. Laryngeal edema and difficulty breathing may also occur, in which case we may have to go for intubation. When AC inhibitor induces angioedema due to bradykinin accumulation, now, the normally AC inhibitor is responsible for bradykinin breakdown. The AC is responsible for bradykinin breakdown, but since we are giving the patient AC inhibitor, there is no bradykinin breakdown, and there is increased bradykinin accumulation that will lead to angioedema. Now, let's see one more question here. So, which of the following is the most likely to be elevated in this patient's serum as a result of our medication reaction? So a 52-year-old woman comes to the emergency department with pain and redness affecting her left leg. The patient's symptoms began 2 days ago and have progressed to the point where she cannot walk without experiencing severe pain. Physical examination shows a large erythematous area with indistinct margins over her left leg. The area feels hot and indurated and is excusably tender. She is admitted to the hospital for severe left leg cellulitis and is started on intravenous cefazolin. Several minutes after the infusion is started, she experiences shortness of breath, diffuse itching, and dizziness. Blood pressure is 64/38 and heart rate is 130. On examination, there is a diffuse erythematous skin rash and bilateral wheezing is heard on long auscultation. Which of the following is the most likely to be elevated in this patient's serum as a result of her medication reaction? Alkaline phosphatase, calcitonin, collagenase, methylperoxidase, or tryptase. Pause the video, think about the answer. Here we have the vignette of anaphylaxis. So anaphylaxis is an immune-mediated reaction or maybe an non-immune mediated reaction. So immune-mediated may be due to medications, food, insect or stings, and non-immune mediated may be due to IV contrast or mast cell activation syndrome. The clinical manifestation include vasodilation leading to hypotension like in our patient and tachycardia. Upper airway edema, bronchospasm can occur with arterial rash, nausea, and vomiting. The treatment is intramuscular epinephrine. So this patient is experiencing an anaphylactic reaction to the cephalosporin cefazolin. Anaphylaxis is a systemic type 1 hypersensitivity reaction characterized by increased vascular permeability and multisystem edema, leading to massive shifting of intracellular fluid to the extravascular compartment. Now, symptoms often begin within seconds to minutes after intravascular exposure to an inciting factor, but can take up to 2 hours to develop with orally ingested antigens. Now, tryptase is an enzyme that is relatively specific to mast cell. An elevated serum level of tryptase are often used to support a clinical diagnosis of anaphylaxis after the patient has been stabilized. Thank you for watching. Keep studying hard.